so much for the kind introduction, and it's my first time here, and I'm really honored to be here. And as Dr. Chang said, happy to be included in one of the few good men. You guys, AWA is doing a fantastic job, really, with regard to sharing the knowledge of endoscopy, knowledge of GI, not only here in U.S., but across the globe as well. And that's really commendable. So thank you for having me here. I'll be talking about refining luminal tissue resection in 2026. So luminal resection has gone really remarkable transformation in last decade or so. What considered to be a surgical domain, now we are able to achieve that endoscopically. We are able to take care of large polyps and even early cancers endoscopically as well. And the goal is really not simply removing tissue now. The goal is choosing the right resection technique for the right lesion. In this age and era, it's really about precision, about safety, minimizing recurrence, and avoiding unnecessary surgery. When we talk about the lumen itself, obviously it's a large topic, including esophagus, stomach, small bowel, large bowel, colon. So I won't be talking about everything in there. I will be mostly focusing on colon polyps here, which is, by the way, is not a small problem. In U.S., we do around 14 to 15 million colonoscopies with 35% ADR. We are detecting close to 500,000 of polyps, and 10% of those polyps are really more than 2 centimeters. So every year, we're adding almost 50,000 polyps, or we have to take care of 50,000 polyps. So we really need to have a technique which is more universally available. We have different accessories to take care of these polyps, and what we want to focus on is the endoscopic technique, which is highly curative, minimizes the need of reintervention, or there's a low recurrence rate, acceptable risk profile, and bottom line is avoids surgery. So we have a biopsy forceps, we have snares, we have knives to take care of these lesions. How do we really select the method and tool? Before I go into these snares and biopsies, I want to talk about colonoscope very briefly. Colonoscope and the endoscope, upper endoscope, they have a different mechanics. The working channel on colonoscope is at 5 o'clock, EGD at 7 o'clock. Got to keep in mind the wheels function as well. We always have been taught when we were fallow, keep the polyp at 6 o'clock position. Why? It's not like just really they're crazy. There is a method behind that madness. When you move the big wheel of the colonoscope away from you, it gives you really good apposition to the bottom. And it moves well like that. When you move the big wheel towards you of the upper scope, it gives you a lot more good apposition to the top. So as a principle, when you're doing a resection with the EGD scope, you're going to have a much better luck if your lesion is from 9 to 3 o'clock position. You'll have a much better control. With the colonoscope, you will have a much better control of the lesion if it's from 3 to 9 o'clock. So the fellows who have not noticed that before, experience that when you do a resection next time. Second thing is about the cap, the clear cap which we use for these resections. So that is going to really help you stabilize the lesion, stabilize the scope. The third thing is colonoscope. Yes, in colon we use colonoscope, but when you are doing a resection in duodenum, use colonoscope, especially when the lesion is at the duodenal apex, second part of the duodenum, or third part of the duodenum. You have noticed that when you're doing a resection, sometimes you keep falling back. Colonoscope, On the other hand, gives you a long position, just like we have a ERCP long position, rests on the greater curvature, and you have a much more stability. Sometimes in the duodenum, it's 75% circumference polyp, then what that's going to do is that's going to really, like you're going to have to keep falling back, and you need a good, really stable position, changing the patient of the, changing the position of the patient. If you put them in a ERCP position, you will be amazed how that polyp gives you access. So sometimes if you are having a trouble, try that, and that will take care of that problem. How do we select the method or the tools? By carefully inspecting those polyps. I won't go into details. We know about Paris classification, or how to look at the mucosal pattern, vascular pattern. Main goal is we're trying to figure out, make sure this is endoscopically resectable or not, because all these lesions are not same. There are granular, non-granular. Granular, G for good. Usually you have a good luck. So you will be able to take care of that. Non-granular, many times not good. And so that you're going to have a hard time with that. If there is a lesion which is fixed, indurated, ulcerated, no point of wasting time on there. They'd likely have a cancer, especially if it's a bulky lesion there. A lot of general GI still use biopsy forceps. I think it should not be used for resection of any polyp, whatever size is. But if you are really, really so much in love with forceps to use that for polyp resection, do not use it for more than 3 or 4 millimeter polyp. Otherwise, what's going to happen is, this is a really good study from Korea. They said any polyp which is more than 4 millimeter, you use a biopsy forceps to resect that. 30% of the time, you're not going to do a good job. So do not use that. Basically, should not use that. Coming to sneers, cold sneer, hot sneer, EMR, cold EMR, I'll talk briefly about that as the time permits. But if you are going to use a cold sneer, use a dedicated cold sneer. The hot sneer, if you use it for resection and using a cold method, no matter how much you go to the gym, how big of a muscles you have, you cannot cut more than 1 centimeter tissue in that. So always use the dedicated cold sneer for that purpose. Cold sneer resection, gaining some traction, a lot of enthusiasm, which is damping down a little bit for different reasons. What is the benefit? Cold sneer does not cut deep into the submucosa, and there's really no transection of the vessel. It's just a blunt trauma. That's why there is not much really delayed bleeding. You do see some bleeding in during the procedure, but not delayed bleeding. Risk of perforation is negligible. Even though there are very talented people out there, they can perforate still, but the risk is really negligible. Heat cuts into the submucosa, cuts the large vessels. That's why really there is more delayed bleeding. How you're going to use the cold sneer, and this is a dedicated cold sneer. You put that sneer onto the polyp. Always try to have a sneer parallel to the circumference of the lumen, not straight, parallel to the wall, and then take a normal tissue around it, close it nicely, very tight, pull that into your cap before you cut it. What that does is that gets the muscularis propria away from you, and then it will cut into your cap, and that would be a very safe way to cut it. It's going to bleed a little bit, which is okay. That usually stops very quick. As I mentioned, a lot of enthusiasm, damping down a little bit. The reason is high recurrence rate, and especially in cases where there is a high-grade dysplasia, the rate of recurrence could be up to 50% in cold sneer resection. So this is not only approved by randomized trial, but also by meta-analysis and different retrospective studies as well. So what is suitable for cold sneer EMR? Anything which is less than 10 millimeter, even pedunculated polyps, Serrated adenomas are good candidate for that, and the flat adenomas, which are less than 2 millimeter. You can inject when you do a cold snare resection. It's not necessarily that you should not do that, but do a good injection. This is the perfect slide showing both bad and good injection at the same time. Injection is a submucosal, not a mucosal. Too much blue is mucosal. Submucosal will give you a white tinge to that. And the way you do injection, I'll show that. And other thing is like have a uniform terminology in your unit. Needle in, needle out means different to different people. So what I say is needle into the patient or needle out of the patient when I'm injecting that. So once the needle goes into the patient, you touch the tissue with the needle tip, start injecting. And then start pushing that needle into the polyp, it will find the submucosa for you. If you just stab it and then try to pull it back, you may start injecting in the peritoneum and start coming back. So that's the way. I'll have some injection video here too. So this is a polyp, which is a cold. I decided to do a cold EMR, even though it can qualify for all of those, but there are really no major factors which show it to be a very high grade, except the size is a little bit bulky too. But if you look at this, I'm getting a normal tissue. I'm starting on the one side. And remember that you do not have to start on the most difficult side. Start at the easy area. That gives you a platform to keep moving forward. And as I said, majority of the time you don't have to inject, but you can inject. Here you see the injection fluid starts going in as soon as I touch that needle with the tissue. Needle goes in, finds the submucosa. You don't have to keep taking the needle out. Just by moving the scope, what we call a dynamic injection. If you move to the left with your scope, injection would go to the right. If you move the big wheel away from you, it will go to the back, move it towards you. It's like, so injection really basically goes on towards the opposite side, and you can use one area of injection and inject a whole lot of tissue there. And this one, still cold snare, even though it's a bit bulky. The reason there is more recurrence rate is because when bleeding happens a little bit in cold snare, we don't pay attention to those submucosal fibers. We leave a tissue behind that. And but this is the end result of that. If you do meticulous really resection, that this is the same patient, and that's I have done like follow up on that patient, and really there was no recurrence. So for hot EMR, bulky, non-granular lesions, thick stalks, any lesions with the advanced feature, difficult to resect, and anything which does not qualify for cold EMR, you can do that. I will skip this video, it's pretty much same. But one thing I want to focus on it, when you run into this fibrotic lesions, you think it's like really nice EMR, you can do, but you run into some areas which are fibrotic. The way I take care of those is what is the suction technique. And this works best with the 1 centimeter snare. Open it up, put it on the tissue, suction that tissue into the cap until it's red out. You may suction muscularis propria in there, but close it really tight. Hold it for 30 seconds there. You may have a deeper layers in there, muscularis propria, but what you do is you make kind of a lollipop there, and then slowly open the snare until you see the wires, the cutting wires of the snare a little bit. And at that time, pull it towards you a little bit, close it. That will let the muscularis propria go away. And you do it a couple of times, and that will take care of that problem. You can do a avulsion of these lesions too. You can do a cold forceps, hard forceps. When you do a cold forceps, hard forceps avulsion, And by the way, that's the only reason I use hard forceps. Otherwise, it should not be used. It's a bigger instrument. It's causes a lot of cautery effect. But with that, use the tip of that forceps, grab the tissue, pull it up, and use endo-cut mode. If you're using a RB or whatever generator you use, more on the cut side than on the grab side, and pull it towards you. Underwater EMR, the concept comes from Dr. Ben Moeller. The reason when he noticed on EUS, the muscularis propria stays same, but the folds in the lumen, they start floating when you put the water in there. So that's how that concept came, and really you can use that to even up to a lesion for up to 2 centimeters. Recurrence does happen. We can prevent that. One is by meticulous resection technique. Second is cauterizing the edges. I don't think it's just the edges which is the problem. Problem may be from the center as well. So when you're using a snare for ablation, when at the edges, don't do from the outside. Start from the inside of the area of resection, and then just gentle underview. Just keep cauterizing that with a soft quack. So now EMR, ESD, anything which looks like this usually is a good candidate for ESD, where you think like it's not, it doesn't make sense. Should I use it? What should I use there? So suspected superficial cancers, non-granular lesions. I won't talk much about that. I'm going to actually maybe even skip this too, but you can do a ESD for fibrotic areas even with the snare itself, snare tip, cut it, and then cut it all around and use a snare really by using a hybrid technique to cut that tissue. Let me see if I can skip there. Yeah, using a snare there to cut that out. So now in this age and era, EMR is still the queen in 2026. We all know who is the boss, obviously, in the house. So it's not the king, it's the queen. And then the reason for that is like you can really resect most of these lesions with the EMR. It's safe, effective. But the bottom line is, in spite of all the hype around ESD, FTR, these other technologies, EMR still is the workhorse of resection, and future is not EMR versus ESD. Basically, is if EMR is enough or when it is not. Managing complications, a couple of more minutes and then I'll finish. I think I'm going over time. When you have a new CRNA in the room, or anesthesiologist, bleeding happens, change it to RDI. They don't even see that. And it looks like a yellow color there. So nobody's panicking. Then you take your time and use a cautery, forceps, whatever you like, coag grasper, and you can take care of that. Perforations do happen, and especially happen when these advanced fellows towards the latter half or last 2 months of their fellowship, they become a little bit more confident. Even when you're telling them that it's a lot of tissue, don't do that, but they still end up doing that. And then you see not a target sign, basically a hole sign there, and then you take over the scope, and we are easily able to take care of these lesions, these complications. You can close those with the clips. I could sense the excitement of pathologists from the pathology report, and it seems like was excited to report all margins negative, including deep margin. So, and I wanted to tell him I knew that. And this video is like if you have a perforation, if you want to make a flap, you want to use an over-the-scope clip, what you can do is make sure that you cut everything before you close that. Don't leave any tissue there. You can make this flap or a patch, basically, just like they make the mental patch. You pull the distal end of normal tissue 1 or 2 folds beyond that, bring it to the proximal edge, and then deploy your over-the-scope clip. That would really close it and bring it both edges very nicely close to each other. And then you can close the rest with the really other clips. So I'll end there. That there is more stuff to talk about, like AI. I think all the hype around ESD and everything else, I don't think that's going to really advance the field. What's going to advance the field is incorporating the new technology like AI into our practice, daily practice, in a way that makes us better to make a better decision to choose the right technique. AI already being used in polyps, still have some issues, can miss flat polyps, descaling issue, but where it really can help us, if it can tell us about the really invasion into lymphovascular area, submucosa, so we can decide between either it's a EMR ESD or it's a ESD or surgery. That's where it's really going to help us. And a lot of other advancement in robotics ongoing as well. Bottom line is we need to use the technique which really is more universally available, and that is it's not about resecting more tissue. It's about a safe, effective, and patient-centered, lesion-centered care for any lesion. So with that, thank you so much.